I want to thank the FSHD Society for giving me the opportunity to share with you an update on a clinical trial preparedness study that we've been running that we call ReSolve. These are my disclosures. What I want to talk about today is I want to start by giving a brief overview of what the ReSolve study is. I know many of you out there are actually participating, and so thank you very much for doing that. But there'll be a few of you who've probably never heard of it before. So we're going to talk a little bit about what we're doing. I'm going to give you an update, sort of where we're at today in terms of recruitment, and then I'm also going to be sharing some of the initial data with you. And then I'm going to finish by talking about some future considerations of doing research like this in the age of COVID-19. As we all know, this has greatly disrupted our lives, and it's also disrupted the research that we're doing as well. So the study is actually called Clinical Trial Readiness to Solve Barriers to Drug Development in FSHD. And while I think that's a pretty practical title, you can tell that it was made up by a doctor. So I'll confess it was made up by me. None of the people working on the study are willing to use that title, so we've shortened it to ReSolve, which is what most people know the study by. The goal of this proposal is really to help us build the tools or the outcome measures that we would use in the setting of a clinical trial, and to help us think about how we design that clinical trial to really help the companies take the next step forward. So why are we talking about this now? Advances in our understanding of FSHD have identified a potential target for therapy, DUX4, this protein that's not normally there, that when it's expressed is causing damage in FSHD by a directly toxic effect. It's really switched the focus of what we're talking about in the research community from what causes FSHD to how we can treat it. Researchers and companies are developing disease-targeted therapies, and there's this real possibility of several clinical trials in the next 5 years, in addition to the Fulcrum trial that some of you may know about that's going on now. The work we're doing on the clinical side really needs to go hand in hand with this work they're doing in the laboratories. And what I'm showing you here is a picture of a muscle biopsy from a patient. It's grown in a culture disc. The green color is your myofibers. The blue are the control centers of the nuclei of the cell, and that pink color is that protein DUX4. Below it, I'm showing you a cartoon illustration of the pathological pathway. What's important here is not the details. You'll hear others talking about that, but each of those arrows represents a potential therapeutic target for a clinical trial. We have had a clinical trial preparedness study before in the late 90s. This was a study that had around 80 people who were followed for 3 years, but this was really before our modern age of genetic testing. So these people were clinically diagnosed with FSHD. We measured things like strength, functional performance, and lean muscle mass. And on the right, you can just see some examples of 2 ways to measure strength. Manual muscle testing, many of you may have had this done in the clinic, similar to how we test your strength. Below it, you can see quantitative myometry, which is more sophisticated and requires some equipment, a table and frame, and digital force transducers. Strength was the most responsive outcome measure from that trial to progression in FSHD, showing changes of about 2 to 4% per year. And so if we wanted to use strength as an outcome measure, and we thought our drug was just going to stop progression of FSHD, we would need 320 people. This is a large number of people for a rare disease like FSHD. But if the drug was going to halt progression but also make people better, you can see then suddenly the numbers become much more reasonable. We also know something about the relationship of your mutation to what happens to people who have FSHD, but these are all from cross-sectional studies. And what we know is that the smaller number of repeats that people have, the earlier they're diagnosed, or you can see on this graph here, the more severe the disease is. Around 200 to 250 on this scale would be people who are maybe starting to require a wheelchair to move around. But what we don't understand is the predictive power of mutation on the outcome measures as we measure them in the time frame of a clinical trial. So we have several gaps in trial readiness. We need other patient-relevant outcome measures besides strength that we can use for clinical trials. We need biomarkers, which are things that may give us an early signal that a drug's reached its target or is having effect before strength or other things may be changing. And we need a better understanding of our genetic and clinical predictors for disease progression. And ultimately, we also need to understand how big a change would be clinically meaningful to someone who has FSHD. Short of looking at these hard things like living or dying or requiring a wheelchair or a machine to help you breathe, we need to think about other ways to think how big a change in what we're measuring would be meaningful. And our ReSolve study will use several techniques for this: statistical approaches, using questionnaires we call anchors, and looking at the relationship of one thing to another. We're running our clinical trial on an FSHD clinical trial research network that I put together with a colleague of mine, Robbie Twill, back in 2016. You can see we have funding from all sorts of different organizations to do this. And we really started with only 4 sites, and then we rapidly expanded to have 8 sites across the United States and additional 3 sites in Europe who are all participating in our ReSolve study, which is a prospective 18-month observational study. This means we're not giving a drug, we're rather seeing what happens to people outside of an intervention. Each of the aims are related to developing the tools we need for clinical trials, or the outcome measures that we'll use for these studies. The people that we're including are adults. They need to have genetically confirmed FSHD type 1. They have to have at least some weakness, but still be able to walk at least 30 feet without the support of another person. And I know some of you have told me before that you're upset because you feel like this has left you out of the study, but we chose these criteria to match what we think the most likely inclusion criteria would be for these early clinical trials. We do have another study that we're starting that I think you may be hearing about in the next 6 months to a year. We're calling it Move FSHD. And this will be a study where we'll have much broader participation. When we look at the kinds of measurements that we're doing in our study ReSolve, I think it's a really fantastic study because it really goes all the way from the molecular up to the whole person. You can see we're collecting blood, serum, and plasma, and this is to allow for development of biomarkers for future clinical trials. We're then looking at things like strength, which maybe have been measured before, but then a whole variety of different functional outcome measures, as well as patient-reported measures of health impact. When you look at when we're doing our visits, the first visit will be split over a couple days, and this is so we can see how reliable some of these measurements are. If we measure one thing one day, are we going to get the same measurement the next? And then the other visits at 3, 12, and 18 months, these are matching likely intervals for clinical trials. I do want to share some of the outcome measures with you in a little more detail. This is an FSHD relevant functional composite outcome measure. And you can see in the left column here, these regions of the body that we chose really came from a large survey that we did, where people ranked the symptom categories that were most likely to affect them and had the highest impact. And these represent the top categories that people identified. We then had our physical therapist go into the literature and choose standard, already existing functional motor outcome measures that we could use to represent those different areas of the body. Some of you may be familiar with some of these things, like the 6-minute walk test, which is how far you can walk in 6 minutes, or ascending or descending a standard flight of 4 steps. So what we get from this is not one outcome measure, but actually a list of 17 different measures that may all be important individually in FSHD. This has shown excellent reliability from one day to the next, and it's shown moderate associations to other things that would be important in FSHD, like your strength or the overall disease severity. Electrical impedance myography, this is a really excellent example of repurposing an existing technology. If any of you have ever gone into a gym, stepped on a scale where it told you something about your body composition, your fat content in your body, this is using impedance. And a researcher had a really good idea to say we could actually design a machine that could give us this measurement over individual muscles. So what it's telling us is something about the muscle quality. It's also shown a very good reliability over large muscle groups. And it's shown very interesting correlations to other things that are important in FSHD. For example, the impedance in the biceps will correlate to the strength in the biceps. The impedance across your legs will correlate well to how you climb stairs or how far you could walk in 6 minutes. And the impedance averaged over your whole body correlates very well to the overall disease severity. Another example of repurposing an existing technology comes with the reachable workspace, which takes that 3D camera that used to be bundled with your Xbox 360 game consoles. If any of your kids or any of you have ever had one that had the 3D camera, it's no longer included in that. But you can see how the researchers used it here. We have people do some standard movements of their arm, and what we get is this volume of space that someone's able to reach into. On the top, you can see someone who's unaffected, and you can see someone with FSHD obviously is having difficulty reaching up above their head. When we look at some of the data from people who are currently enrolled in the ReSolve study, what I'm showing you here is some of the data from the first 128 individuals who joined our study from the United States. We currently have 217 people who've joined the study from the US and the European Union, and I want to thank any of you on the presentation today who are currently involved, because you really made this possible. And we still, after the COVID-19 pandemic eases up and we start enrolling again, we'll have at least another 9 people who will be enrolled in the US. But looking at this initial group of 128, we can see a few things. We're getting an equal number of men and women. You can see that overall, people are middle-aged in the study, but we're really spanning that full adult age range. Most of the people who've enrolled are Caucasian, but we do have several efforts underway to try to reach these more underserved communities and get them involved. When we look at the disease characteristics of these first 128 people, we can see a few things. If we look at the average age of symptom onset, you can see it's 26 years of age. This is just slightly older than other large groups of patients that we've seen reported on, where that's usually between 20 and 25 years. And this may reflect in this initial group of 128, that slightly older mean age of onset. When we look at that difference between when symptoms started and when people were diagnosed, you can see it's about 10 years. And this is quite consistent in several large studies where we've been able to look at this. Is the average amount of time between when symptoms start and when people are diagnosed. If we look at the mutation size, you may remember that the number of repeats in FSHD can range between 1 and 10. So we've really got a good span of mutation to try to understand how that's affecting some of the measurements that we make. And you can see below it here, this CSS stands for a clinical severity score. It ranges from 0, which would be someone who is unaffected, up to 5, which would be someone who really was requiring a wheelchair for all activities. So you can see, again, we're spanning really that full range of severity. So I think we've got a good sample to help us understand our outcome measures. I do want to show one example of the power of a large study like this to start to evaluate these instruments that we use. And what I wanted to do was to show you this clinical severity score I referred to on the previous slide, you can see each of the elements of the scale listed out for you here. Notice that it really follows this progression that we see in the disease with the face and the shoulder, then first the distal legs, and then the more proximal lower extremity involved later in the disease course. We can do things like look at how many people have each of these different severity scores over the group. And for those of you who've ever looked at group data before, you know there's something called a normal distribution where you really expect this to look something like a mountain. You can see we're doing pretty good with this score, but many of you probably have noticed something's going on between this 1.5 and 2 and 2.5 where there's a dropout. And so a study like this can help us understand where our scales may be deficient. In this case, if we look at 2, it's severe scapular involvement with an inability to lift the arms above 60 degrees, an inability to lift objects. And so what's likely happening here is at the point where people have that amount of weakness, they already have lower extremity involvement. And then you can look at a company like Fulcrum who's used this in their inclusion criteria for their clinical trial, where they were taking people with scores between 2 and 4. And you can see that that represents about 70% of a population who are still able to walk. I want to take the rest of my time to just talk about some of the ways that things are changing in the age of COVID-19. And this has obviously hit all of us very hard. The whole country is still reeling from this. I'm showing a photograph of an album from the Beatles called "And the Band Plays On." And I like this phrase because there's 2 ways you can think about it. One way would be that the band's playing on and it's oblivious to disaster going on around it. But another way to think of it is the perseverance of the human spirit, playing on even in the setting of disaster. And I have to say we're committed to continuing the FSHD research mission despite COVID-19. All of the things I talked about at the beginning are still there. We still have a need to develop these tools for clinical trials. We still have several companies that are developing therapies. There's also potentially a silver lining, and some of you may have already seen this in clinic. Telehealth visits in clinic, we've been lobbying for these for many years, and now you may notice we're actually able to do them in many of our clinics. And by the same measures, we've been working very hard to push forward remote assessments for clinical trials to allow people to participate from home, and we're making some headroads in that category as well. There are many ways that an observational study like ReSolve might adapt, but each study and each site may be different. So if you're in our study, I'm really going to encourage you to reach out to your local research coordinator. But some of the things that we're already doing, we're mailing forms that people can complete at home to you so you can continue to collect them at the times when we're expected. Now, your experience of FSHD during the pandemic is going to be important to understand. This is part of all of our natural histories right now. Whatever answer is right for you is the right answer, unless the question would specify otherwise. We're also expanding our visit windows. For example, a typical 12-month visit will let people come in anywhere from 9 months to 15 months. This is to really help us keep people enrolled in the study and get as much information as we can without having missed visits. If the pandemic was to keep going on and we had prolonged closures, we might then add more remote assessments to our study. Now, many of our sites, as are many of the states in the country, are in the process of reopening. And as we do, your safety is going to be our first priority. If you go into a visit, you're going to notice several changes that will be there. For example, you'll likely be asked questions about whether you've been sick or around anyone who's been sick. Your temperature will be checked. You and other participants, as well as the staff, will all be wearing masks, and the staff may also have other protective equipment on. And they may ask you to come alone or with just one person to minimize the number of people in the building so we can maintain social distancing. But finally, we need you to stay involved. I know it's a rough time, it's hard, but you need to check each site and each person in your own location. You're going to have to figure out what's right for you. But for us to succeed, we need you to stay involved. And so we're really encouraging people who've already enrolled to stay involved with the study, to reach out to your local coordinator and understand when the study will be opening back up. And as you know, we send out a newsletter and we'll be in touch with you to let you know more about this. I wanted to end the talk like I always do, just by pointing out there's several ways that people can be involved in studies, either reaching out to us directly, looking on clinicaltrials.gov, going to the website for our Clinical Trial Research Network, or going to the websites for the FSHD Society, Friends of FSHD Research, or you can register with the National Registry of FSHD Patients and Families. I want to thank you very much for your time.